Hello, guys. Welcome to my podcast. In today's podcast, we have another guest. Here with me is Dr. Nicholas Downey. He's from South Africa, and he's basically a medical doctor with an interest in PED. So that's why I invited him to be the guest of today's video. So just to start, I would like to give you a few minutes so you introduce yourself on short.
Hi, everyone. I'm Nicholas Downey. I'm a medical doctor with an interest in PEDs. I'm interested to discuss whatever topics we have today. Thank you for having me on.
No problem. So in today's podcast, we've decided that we're going to talk about how we can protect our cardiovascular system from the harmful effects of steroids and other PEDs, but mostly talking about androgens today. So where should we start? There are plenty of things that androgens can affect regarding our cardiovascular system.
Yeah.
If we're talking the lipids, if we're talking about our complete blood count, they are erythropoietic compounds which can increase the hematocrit, hemoglobin, erythrocytes, and cause polycythemia. Then we could also discuss things like blood pressure, for example. Or maybe I will just give you the word, so you tell me where to start. What should if I'm say if I'm a regular guy that comes to you hello doctor, I'm on steroids, I'm doing let's say tests and this and that. What should I do in order to protect my cardiovascular system so I don't damage it, or to say so I can mitigate the damage?
I'm sure a lot of people are aware of it by now, but one of the biggest risk factors with anabolic androgenic steroid use is cardiorenal syndrome, or just overstimulation of the renin-angiotensin aldosterone system. That is a massive cause of a lot of problems that bodybuilders have. It leads to, obviously, the increased blood pressure. And the problem with an increased blood pressure is this causes an increase in what we call afterload of the heart, which means the heart has to work harder to push essentially the blood. And this increase in afterload leads to what a lot of people nowadays know as left ventricular hypertrophy, or LVH. So that's one of the most important things is obviously controlling your blood pressure, because steroids stimulate the system, which leads to an increase in sodium retention, water retention. This increases your blood pressure. But they even found that in individuals who have normal blood pressure, so I always recommend when people are starting steroids to use an angiotensin receptor blocker or an ACE inhibitor, just because even if your blood pressure isn't high, they found that in hearts of individuals who were normotensive, so didn't have high blood pressure, that this elevation in aldosterone and corticosterone led to issues such as cardiac fibrosis and hypertrophy. So what we want to do is we want to reduce the amount of these hormones that your steroids are stimulating. And the best way to do that is through an ACE inhibitor and an ARB. Or an ARB. You don't use both. So that's essentially where I start off. But there are many other causes of cardiovascular disease, as you've outlined, with the increase in hematocrit and things like that. So that's one of the biggest things I tackle. And then another issue is sympathetic nervous system overdrive, essentially, where I don't know if I'm sure a lot of steroid users know about this, is the increase in heart rate. And the problem with a sustained increase in heart rate is not only could it possibly lead to an arrhythmia, which can be lethal, it could also lead to tachycardia-induced cardiomyopathy, which is essentially enlarging or this myopathy of the heart as a result of uncontrolled heart rate. So not everyone needs this, but in heavier power lifters, I always tend to go on the cautious side and possibly recommend a beta blocker, but it's a bit. That's a bit more of a touchy subject. But yeah, that's two of the big things in terms of just the heart. Then you get atherosclerosis, but yeah. What's your take on it?
I just wanted to mention, like when you were talking about the inhibition of the overactivation of renin-angiotensin-aldosterone system. So just lately, like 4 months ago, I've managed to get a prescription from my doctor for telmisartan. So currently, like I started it on 40 milligrams per day, but then I increased because like doctor prescribed me 80 milligrams. Like I didn't really need it. Like honestly, my blood pressure is like it is high sometimes, but like only if I like push the food and like I hold the extra water, then it might get up to like 140, 145. But like most of the time, to say my blood pressure is quite fine. It's like between 125 and 135, something like that, which is probably like quite fine for someone that is more than 100 kilos fasted.
Exactly.
So, but still, I was like looking into the benefits of telmisartan and how it can like mitigate the negative effects of androgens that have on our cardiovascular and renal system. So I asked my doctor about it, and she was very enthusiastic about it, and she was like, "Okay, yeah, sure, you can take it because like it will protect you and all that." So that's why I said like, "Sure, like I will use it, even though I don't really need it, but like just as a protection, so I can mitigate the damage that I'm causing to myself." So I started with 40 milligrams per day, and then after like I didn't have any side effects at all. Like I was also like monitoring the electrolytes, so no hyperkalemia or anything. So I increased it to 80 milligrams, and I'm just staying with that right now. So also like, but that's probably like a topic for another video to discuss, like more about the angiotensin receptor blockers. And
they're a large class of drugs.
If you need to, let me just ask you, like I usually don't really like to start with, like if a client has high blood pressure, I usually prefer ARBs over ACE inhibitors just because they tend to have less side effects and they usually don't cause hypotension and stuff like that, like ACE inhibitors usually do. So like, would you agree with me on that? And like what ARB or ACE inhibitor would you prefer to do? Like, is there a specific one that you would pick?
So in terms of efficacy, both are as efficacious, but so I come across ACE inhibitors a lot more because I work in the public healthcare system where ARBs are a bit more expensive. And the only time we would swap a patient from an ACE inhibitor to an ARB is if they suffer from either the chronic cough, so a dry cough is a common thing that happens with ACE inhibitors, or angioedema, which is quite dangerous and is a complete contraindication to using ACE inhibitors. So essentially just swelling, possible airway obstruction from ACE inhibitors. So in general, ARBs are more tolerated. They tend to be a bit more expensive, but they're really not that expensive. If you're already taking steroids, you can afford an ARB. I'm talking from a public healthcare standpoint.
In my country, actually, you don't pay anything for medications that you get prescribed from a doctor because like that's how it works here, So but also what I also wanted to say. So is there any like ARB or ACE inhibitor that you would recommend like over like is the telmisartan, or do you find any other to be better? And what about the ACE inhibitors?
In terms of like morbidity and mortality, they more or less have the same outcomes. However, a lot of people are starting to take telmisartan because they have that perioxum something agonist activity, which kind of works similarly to cardarine, so it's more beneficial from a cardiac remodeling standpoint. So telmisartan is favored from that standpoint, although in practice I come across losartan a lot more. They all seem to work more or less the same. Both are are renoprotective, both are cardioprotective, as well as assist with remodeling. The data to suggest which is better than the other is still fairly limited, and we don't know if it's clinically significant. So, like, yeah, sure, there might be a study that says this, like telmisartan has that extra cardiac remodeling ability, but if we look at the long-term data, the outcomes are the same. So it's like, is it really that much more beneficial? We don't really know that, but I mean, if you can afford it, I don't see why you wouldn't take something like telmisartan. Although I've seen better. This is anecdotal from what I've seen. Telmisartan doesn't seem to lower blood pressure as much as other ARBs and ACE inhibitors I've come across, which is a positive thing for a lot of people who are, as you say, normotensive, have normal blood pressure, but would like to possibly combat the side effects of steroids. So it's good from that standpoint. But yeah, ACE inhibitors, they're dirt cheap. But yeah, if you can afford an ARB, you should go with it, just because you don't want to play around with possible side effects of an ACE inhibitor. But the general opinion is a bit contested there.
Yeah. Okay. So that's regarding the blood pressure. Is there any other, what would you tend as a doctor, if I ask you what blood pressure would you recommend to maintain around? Would you be if someone has a 145 for a certain period of time, would you treat that as well? Or would you be okay, that's kind of fine if you're a bodybuilder for a certain period of time? Or
So yeah, it's a lot of people think when I touch on this topic that I'm over-treating. However, you have to look at a steroid user from a different aspect. It says you only want to control blood pressure to a tight control of blood pressure when people have other morbidities or risk factors. And I think most steroid users do have risk factors, and that's the steroid use. So getting blood pressure control to be as tightly controlled as possible, so less than 120/80, is probably optimal. Even in cases, I've come across doctors who have been in practice with a lot of clients who are PED users. They like 110/70, somewhere around there. And that's mostly because you're already going to get, whether or not you control your blood pressure, or even if you control it, you're still at an increased risk, just based on, small-scale studies that show steroids, even if cause hypertrophy of the heart, cause renal damage, which is another big issue, even when blood pressure is controlled for. So I think it's important to ensure you mitigate anything or control everything you have the ability to control. If you can control it, you might as well control it.
Yeah, of course. Makes sense.
I don't know what your opinion on that is.
No, I'm pretty much the same. Usually I don't, it's hard for most people to keep their blood pressure under, let's say, 135. To be honest, most of the bodybuilders, a lot of them, they are just hypertensive, and if you add them an ARB or something like that, their blood pressure will still be 130 or something like that. Usually it will be very hard to get someone that is into bodybuilding, doing lots of drugs, bulking and all that, into 110 range, unless you put him on very strong antihypertensive medications, for example, combination of ACE inhibitor with an ARB or something like that. But then again, there is the question, do we want all these extra medicines just to lower our blood pressure a little bit, because then they can also have some other potential not benefits, side effects like hyperkalemia or something like that, and people are just not educated enough about them. And if you don't have a doctor above yourself to control you, and if you say to someone, okay, now you should take telmisartan, you should pair it with ACE inhibitor just to keep your blood pressure under 120, then it might get into he might run into some problems, So yeah, usually I really agree with you. Like I usually tell people like keep your blood pressure like under, let's say, 135 over 880, something like that, So I don't really like
which is reasonable.
Yeah, like I mean, I don't really panic if my client like sends me a blood pressure of 140 if that is just like for let's say a week or two, like probably a high blood pressure for just like a short period of time won't do you much damage, but it's like more like how is your blood pressure over the years, Okay, so first thing that we already discussed, like how to protect our cardiovascular system, we would probably both agree that we need to control our blood pressure and keep it in the healthy range for most of the time, right? Now, moving on to the second thing that many people are not paying much attention to is how to say blood viscosity. So, like how thick your blood is. Like many steroid users, steroids are, as you probably know, erythropoietic compounds. So they stimulate the production of erythropoietin, which then stimulates the production of red blood cells. So oftentimes, a lot of people that are already genetically predisposed to polycythemia, when they go on steroids, their red blood cells, hematocrit, hemoglobin just too high, and then they are like checking the blood work, and they're like, okay, it's fine, it's not like too much, but like over the periods, like over the longer periods of time, that's definitely not good, because like your blood is sicker, your heart needs to work even harder to pump this blood, then this can also be like the separate factor for hypertension, and like you have increased risk of blood clots, like DVTs, pulmonary embolism, and all that. So how can we treat that? Like, what can we do if I come to you and I say, like, hello, doctor, my red blood cells are through the roof. Like, what can I do? Like, I don't want to take steroids. I still want to take steroids, but, like, what can I do besides quitting steroids in order to control my polycythemia?
I mean, this is a common one, Joe. I pretty much every client of mine is someone who come to me with extremely high hematocrit and hemoglobin levels, and obviously don't want to stop steroid use, which is like, I'm not going to force you to stop them, but obviously the best thing to do is stopping the thing that's causing it. But in a lot of situations, people don't want to do that. So what I do instead is we switch around compounds and avoid those that are known to raise your hematocrit. We do therapeutic venesection, blood donation. You can't really donate blood if you're on anabolic steroids. It's unethical, supposedly. So you can do like, you go to a hospital, get venesected instead. But the problem with that is, whilst it will benefit someone who has extremely raised hematocrit and hemoglobin from acute problems of a raised hematocrit or polycythemia, it's not really going to reduce morbidity and mortality as much as we thought it would. So whilst it will reduce you from those from like acute complications such as thromboembolism, like a DVT, or I don't know, but essentially they found that it actually doesn't decrease the risk of heart disease and hypertension and things as much as I thought it would. But that's the gold standard. Venesection is a gold standard, but I tend to play around with different compounds just because I'm aware of the data that like says that whilst venesection will stop you from having like an acute stroke or something, it's not going to prevent the long-term consequences of a hematocrit, even if a raised hematocrit, even if you regularly go and bloodlet. So yeah, I'd rather just control it with the drugs, as I said.
And what drugs can you use actually in order to control it? You talked about the steroids, right? So yeah, definitely like makes sense that you.
Yeah. There are no like drugs at this point in time. Yeah.
Yeah, I think ARBs and ACE inhibitors can help with that a little bit, but like I didn't notice much in myself, Also about the steroids, like probably makes sense. if you're polycythemic, you won't be like using boldenone, for example, but you will maybe honestly,
Exactly.
what steroids do you think are? Because I didn't research that much. Like, what do you find to be the least problematic here? In order,
I mean, I hate ever like giving credit to the class of 19 nor testosterone and such, but I have never really seen issues with individuals using Tren, Deca, or Mint. Not that I promote them at all, but obviously, if you're going to take them, I don't care. But I'm just saying, like, people, it's like a controversial topic. No one likes giving benefit to the 19 nors over other drugs, but yeah, I haven't seen an issue with them. So I have, in certain cases, gone with. As for people on TRT who like don't want to stop TRT or try a different form of TRT, we have tried Mint, and it seems to work fairly well. So that's just in terms of swapping out compounds. Using 19 nors in certain circumstances, like if you are using boldenone and primo and such, I know I don't want to say this, but it's like maybe perhaps consider Deca or something else if you're like if you want to be a big bodybuilder and you don't want to stop steroids. Maybe consider a 19 nor instead if it is a big issue. I don't know. It's such a controversial topic.
Yeah. Sure. So to conclude on short, like, how would we control polycythemia? First would be the compound selection, so we are not using the most erythropoietic possible steroids. Then second would be to maybe try with some ARB, like, because they do help maybe a little bit.
Yeah, I have seen data around it. It's there, but it's perhaps not as significant as we might think it will be. It does like lower the points, but like in the setting of someone who is extremely polycythemic, I don't know if it will help that much. But yeah, from a preventative standpoint, they could be used. Perhaps limiting heme iron intake and going for like non-heme iron sources like plants more. I know like people love their red meat and such, but going for more like plant-based protein sources and things like that, or just including more vegetables with your animal sources of protein could help limit the heme iron absorption. Trust me, no steroid user is going to become, low on iron. I've never really seen that.
Okay, so and then like if nothing of this helps, like maybe go to a doctor and do like therapeutic phlebotomy or something like that. Even though you said like
I mean, I would recommend doing that. Yeah, I would. If you are like prone to it, why not just do it as like a preventative measure? It's not going to help you in the long term, but perhaps in the short term from any of those acute complications. Yeah.
How about using aspirin for people who are polycythemic? Do you think it could be useful?
Yeah, I've seen a lot of YouTubers discuss the use of baby aspirin. In my opinion, I've seen it. We've discussed it a lot when I was doing my rotations in internal medicine about the using aspirin prophylactically for things like reducing gastrointestinal cancers and such. And the issue with aspirin is it can cause issues like hemorrhagic stroke and other complications. But in the case of a steroid user, now that the problem is we don't have the data, but it makes sense to use it from that standpoint because it is prescribed after someone has a heart attack or a stroke. And we know that steroid users are at risk of a heart attack and a stroke, so it would make sense that you would use baby aspirin. But there is still that risk of gastrointestinal bleeds as well as hemorrhagic strokes, so it's more or less up to you. I don't know what your opinion is. Mine is still kind of mixed, but maybe it might change.
Honestly, I don't think it's that much of a problem if you're a bodybuilder and you already have like high hemoglobin and everything. Like I wouldn't say it's that much risky to take aspirin. Like that's my opinion, honestly.
Yeah, that's probably more reasonable. Yeah.
Let's move on to, so now we covered the blood pressure, the polycythemia. Now let's move on to maybe lipids. So how like steroids can negatively affect our lipid panel, so that's our cholesterol. Like they can decrease the good cholesterol, even low dose of testosterone can do this. So it can wipe out the HDL while they can increase the LDL. So usually, like the most notorious steroids for like skewing up your lipids are known to be oral steroids. So things like, I don't know, Winstrol, Unabol, like they usually tend to like cause your lipids to go like into trash the most. So what can we maybe do about it? Like how can we treat our dyslipidemia? So how can we increase the HDL? How can we decrease the LDL? What would you say?
Yeah, in terms of increasing your HDL, there isn't much you can do besides like lifestyle interventions. However, cardarine in certain trials did show there was actually a trial where cardarine was used in adults, and it did increase the HDL level of those individuals, whilst lowering LDL. So HDL is a bit of a difficult one that I don't focus on too much. That's if your LDL is also low, because then I prefer to use the LDL-HDL ratio. As long as your LDL is low enough, it doesn't really make a difference with HDL. Still, the data around whether HDL is an important cardiovascular risk factor is not as strong as that for your LDL. So I tend to focus on LDL because I know with a steroid user, the HDL is going to be non-existent. But in certain circumstances, like with TRT at proper therapeutic dosages, it can actually decrease your LDL and increase your HDL. I've seen that a few times. Otherwise, it's more dietary related. If you're on steroids, you're going to want to ensure you're eating as clean as possible, because you're going to get skewed lipids in some way. And then avoiding orals if you don't need to use orals. It's like you don't need an oral in an off season. Sure, you could probably use Anadrol, but you don't have to. But that's just my opinion.
So when you were talking about the diet, so I've noticed it myself that like eating plenty of fiber and oatmeal really can decrease your HDL.
Exactly. Yeah.
So like I myself, not HDL, LDL, sorry. So I myself, I most of the year I eat a lot of fiber, probably like 3 times the recommended dose, amount for an adult.
Same here.
So I usually on diets I eat lots of vegetables and all that, and for my carb source I oftentimes prefer oats over the rice and that, because they are simply more nutritious.
Yeah.
And, they also have this I don't know exactly, I think it's called beta glucan that was shown to lower cholesterol. And like last time I checked my lipids was like 4 or 5 months ago, I think something like that, and my LDL cholesterol was below the reference range, so it was really good, and my HDL cholesterol was a bit low, but like wasn't too bad low, like it was still like kind of good for a steroid user. And now I checked my blood work.
That's usually the case.
Yesterday I checked my blood work again, and like HDL is pretty much the same, but LDL did increase a bit, and I think it's due to me not eating as much fiber lately because I was on a bulk right now, and I was eating like 5,000 to 6,000 calories per day. And I like when you're eating that much food, like you're not like really eating lots of vegetables besides, And I wasn't like I got a little bit sick of oats, so I replaced oats with rice, and I automatically like just removing the fiber from my diet, it increased my LDL cholesterol. And then also probably like me introducing more of those like sauces and like not very healthy fats, So like I like 99% of the time I eat clean. I don't even have cheat meals except sushi and all that, so I don't eat any junk. But like even that was enough. Like even the reduction of fiber in my diet and the increase of fat was enough to like increase my LDL. So now what I'm gonna do is like I'm just gonna implement more fiber into my diet. And like my LDL is still fine. Like it's still well inside the reference range, but it's higher than it used to be like 4 months ago, And then besides that, I was like, once I used it with my client, it's the drug called ezetimibe. If you have any experiences with it, it was really good. Like my client had high LDL, and I gave him ezetimibe, and like even like after 2 months or so, his LDL went down a lot. So what is your opinion on ezetimibe?
Correct me if I'm wrong, as I'm going to be drawing from like third year pharmacology knowledge on ezetimibe. But essentially it's like a plant sterol. That's what it was made from, which is essentially just blocks your gastrointestinal intake of cholesterol. So so essentially it does work, not to the extent of statins. It doesn't reduce morbidity or mortality as much as statins do, but that's because statins have pleomorphic effects. But in terms of I think you could replicate the effects of ezetimibe just through increasing fiber intake, because it essentially does the same thing.
And also, like besides ezetimibe, what natural supplements do you find useful for treating high cholesterol? Like for example, I noticed that like I usually practice with people that have high cholesterol and also with myself. I have good cholesterol, but I still take those things. So I find berberine, fish oil, and garlic to be good natural supplements for cholesterol. Like, do you have any other in mind?
Yeah, I know that those do tend to work quite well in terms. I know that people use citrus bergamot, or as well as niacin, which is just vitamin B3. But in terms of like fish oils, I have seen it work very well. Just from looking at clients and such, it actually helps with decreasing hematocrit also, I've realized. But yeah, those supplements you mentioned are definitely very efficacious. And I don't know, a lot of people like using ezetimibe, but purely if you're going to use ezetimibe, you might as well try a lifestyle intervention instead, because it will work as effectively as ezetimibe. But obviously, that's not possible if you are bulking or something. So,
yeah, you can maybe keep cardio in your round. That should help as well. Doing lots of cardio.
Exactly.
Mm-hmm. And okay,
exactly. So lifestyle measures work well.
So to conclude on short, like if you have screwed up lipids, first pick the right drug choices. So maybe not use as much orals and all that, but mostly stick to healthier injectables. Then, of course, make sure that like your other lifestyle things are in place. So your diet is clean. You're eating plenty of fiber. You're eating unprocessed food. You're eating healthy fats. You're like all that. You're eating as clean as you can. And you're doing cardio year round. And then you're adding in natural supplements first, like maybe berberine, citrus bergamot, garlic, fish oil, and that. And then if that doesn't help, you can try with ezetimibe, and then probably like the last thing would be statins. But like, what is your look on statins?
Exactly.
Like, how effective they are. Well, probably they are really effective, but like, what are the side effects of the statins? Like, are they dangerous? Like, can they cause a lot of like negative stuff and all that?
Yeah, so in terms of statins, a lot of bodybuilders don't like using them because their biggest side effect is myositis or myalgia, which is essentially just pain in the muscle. It's a very common side effect of statins. They have other side effects. Sometimes they can increase your liver enzymes. However, that's not the biggest problem with them. But it's mostly the most severe side effect is rhabdomyolysis, like breakdown of the muscle, which leads to kidney failure. And a lot of people have bodybuilders say that they don't want to use a statin because it would decrease their gains, essentially, which there actually is some evidence to support that it does decrease lean muscle mass as well as strength. So they work really well because they don't only decrease your cholesterol levels, but they also stabilize any plaque formation you already have in the heart. So the reason why it would be your last resort is because they do come with side effects that the other methods of reducing your cholesterol won't come with. So yeah, I like your stepwise approach. That's how everything should pretty much be managed. It's like lifestyle, then mild drugs, and then you go escalate up. But yeah, so statins, in certain circumstances, I think they're needed. Others, maybe not.
Okay, so I think what we covered now, 3 things. Now, the next thing I want to talk about is structural changes to the heart, like negative cardiac remodeling that anabolic steroids can cause. So, like, first thing would be like, probably this is like very closely correlated to the overactivation of renin, angiotensin, aldosterone system, and having elevated blood pressure for the longer periods of time. So just by like doing that and having this in place, like managing your blood pressure and taking some telmisartan, you can do a lot about it. But like, what else can we do in order to like prevent all this negative cardiac remodeling of our hearts?
Well, it would be blood pressure would probably be one of the biggest risk factors, and especially your systolic blood pressure. And a lot of people look at their heart and think left ventricular hypertrophy is the biggest thing they need to worry about. But I actually had a client, we were looking at his echocardiograms, and he was more focused on the fact that he had mild left ventricular hypertrophy, which was actually doesn't concern me too much, but obviously you'd want to take steps to make sure it doesn't get worse. But another common thing that a lot of people don't look at is left atrial and aortic root dilatation, which is very common. So aortic root dilatation, essentially at the start of the aorta, the big vessel, the artery that, goes through your body, supplies the blood, that expands. And the problem with this is if it expands too much, you get a tear, and then you can get an aneurysm or dissection. And this is how Boston Lloyd yeah, exactly. And a lot of people don't look at that. They look at your left ventricular hypertrophy. They're like, oh, no, it's fine. But it's like, look at your aortic root. See, like with this client, we actually had his echocardiogram, many different ones, and we saw that it was gradually increasing. His aortic root was gradually increasing. He's an older individual, and so we needed a bit more tighter control on his blood pressure than a younger individual would. But it's an important thing to take note of that a lot of people tend to ignore. They think left ventricular hypertrophy is the be-all and end-all. But yeah, so that's just something I've always wanted to bring up and like put out there because a lot of people don't look at it. But another important thing is cardio. Like, it sounds so simple, but cardio is one of the most beneficial ways of positively remodeling your heart, and it's underutilized by a lot of people.
I do cardio every day, year round. 30 minutes a day plus
Yeah, it's
15,000 steps a day. So I do a lot of cardio. Because I also practice that with my clients. Like I never understood why bodybuilders in off season, why wouldn't you do cardio? Like it has so many benefits.
yeah.
It actually also builds muscle. Like last time on the podcast with Alec, we talked about that energy expenditure induced by cardio actually stimulates one of the very powerful growth pathways, mTORC1, that it's actually anabolic. So that's why some coaches, some bodybuilding coaches, got their clients doing like 2 hours of cardio in the off season. So there's literally no reason not to do cardio, in my opinion, because it has so many benefits, not just for your cardiovascular system, but also for your like insulin sensitivity, your digestion, how you feel, like everything, So literally, like doing
Yeah,
cardio,
I
you
agree.
can do it year round. Like no matter if you are on bulk or on a cut, you should be doing like 30 minutes of cardio at least every day.
Exactly.
I also wanted to ask you what can we what tests do we need to take in order to check how our heart is doing? So is it the echocardiogram enough, or should we also do some ultrasounds in that?
So in terms of, it depends on who your doctor is and their ability to utilize the echocardiogram. But I would say for me, I'm most comfortable with that. A lot of times with clients, I can even use ECGs just to make them feel comfortable about left ventricular hypertrophy, because you can calculate it on an ECG. But for me, it's echocardiogram is probably the best way to view the heart. You can do an MRI of the heart, but that's just unnecessary, because it will pick up small change, but whether or not that's significant is really contested. So an echocardiogram is enough. I'm happy with an echocardiogram, because the measurements, especially if you have like a baseline and then you do them every year or so, it's one of the best ways to see how your heart is doing. You can measure your ejection fraction, you can measure the sizes of the wall, everything, the valve function, everything you need is pretty much there.
Interesting. So next time I'll do it, I'll send it to you into DMs so you give me the info, because like honestly I don't know how to read this. Like do you like really
It's not bad. It's not bad.
Okay, so did we cover everything right now, or is it any? Oh yeah, about the what is beta do? Like, correct me if I'm wrong, but like androgens can stimulate the beta adrenergic receptors on the heart. Therefore, they increase the how to say adrenaline signaling, and they increase the heart rate. They can increase the heart rate, even though I didn't notice that with myself. Maybe also because I'm doing like lots of cardio and all that. But like if I look on my Apple Watch, like I have like a 53 resting heart rate, which I think is pretty good.
Okay. Yeah. No, that's the thing. Like, if you do your cardio and you keep healthy, a lot of these drugs start becoming unnecessary, especially if your resting heart rate is less than 60. Because for a lot of the heavier guys, their heart rates are almost, I would say, like close to 100. And in that case, then we start like implementing pharmacological treatment. But if you do cardio, and you're lean, your heart rate is going to be well controlled, which again is important when we look at the heart, because having an uncontrolled heart rate just leads to a whole bunch of problems.
Yeah, of course. But like honestly, even if I would have a client, like first thing will always be the cardio. So like I somehow I don't like the beta blockers if they are not needed, because like they literally can affect the function of your heart. So like if you're a bodybuilder and if you're starting to take beta blocker, then you're like literally like your training sessions won't be as good, because like you're slowing down the rate, your heartbeats and all that. So beta blockers would, in my opinion, be like the last thing I would look at. So first thing I would always like say to people, like lose some weight, don't be too fat, like control your water retention, do your cardio, do more cardio if needed, and then if it's still not enough, then maybe look into a beta blocker.
It's with beta blockers. That's why there's like this popularization around nebivolol, because it supposedly doesn't cause a blunted effect in the gym. So like your heart rate won't be, it will compensate for your extra workload. So beta blockers are needed. Not most cases, but they actually, a lot of people actually don't know this, but they actually improve the contractility of your heart. So they actually improve your ejection fraction as well as support cardiac remodeling. But the only time I'd use that is in cases where we start seeing moderate or ejection fraction of the heart decreasing. So for the most part, they're not needed.
Mm-hmm. Okay, so I think we've covered everything. Is there anything more that we need to talk about?
It's whatever you think you'd like to discuss.
Of course, we could discuss more into the details, but I think we've covered the most important things. So we've covered the overactivation of renin-angiotensin system. We've covered the blood pressure that you should control. We've covered how to control polycythemia. We've covered the lipids. We've covered the heart rate. We've covered the cardiac remodeling. So is there any other way that androgens could potentially negatively affect our cardiovascular system besides everything that we already discussed? Or is it everything?
I think I'm sure there are many other ways, I think we've highlighted the big ones.
Yeah, so probably if we control all this, we will greatly mitigate our long-term risk of androgen use. So, also, maybe I just have a question for you. What are your thoughts on using 5 to 10 milligrams Cialis per day for cardiovascular benefits?
I'm in support of that, especially for bodybuilders. I find it more beneficial from a renal standpoint. It seems to help quite a lot with relieving the load that the kidneys tend to get from, working out. Those increase in blood pressures when you're doing a leg press or something like that. It definitely helps with that. And I have seen it improve glomerular or your GFR. I can never say it. And I've seen it in myself because I've taken Cialis 5 milligrams for this entire year, and my creatinine and obviously with the lowering of my creatinine, my GFR has increased. So it's definitely beneficial. It helps with blood pressure. There are many other aspects of it. I think I have made a video on it, but I favor it quite a lot. Yeah.
Yeah, I also take it right now, 5 milligrams a day. Maybe before sex, I take 10 milligrams. Also, I've read that it's very protective towards prostate. It protects against prostate hyperplasia.
Yeah, it is. It's well, perhaps not. So I don't know about the protective ability, but we do use it in urology for people with BPH to relieve those symptoms, which in turn takes strain off your kidneys because you're not having such high increases in your voiding or residual bladder volume after peeing, because if you have an enlarged prostate, you're not going to be able to pee everything out, which increases the volume and the pressure in the bladder and up into the kidneys, which can cause damage to the kidneys via that route. So yeah, it has many benefits.
Mm-hmm. Okay, so maybe just the last thing, and then we will end this podcast, is my question for you. If we have the wide spectrum of anabolic androgenic steroids, so which one would you say are the safest in terms of cardiovascular risk, and which one would you say are the most dangerous?
I get asked this one a lot. So obviously, number one in terms of safest, probably would go with the one we have the most data for, and that would be testosterone, because in individuals, it has been shown that at therapeutic dosages, it actually can be protective against your cardiovascular system. In terms of other compounds that might be favorable for your heart, I would say anything that doesn't massively increase your blood pressure or overstimulate you. So something like tren would be out of the window in that circumstance, just due to the overstimulation, and I think it does remodel the heart unfavorably. So then I would go for testosterone. Primo does skew your lipids a bit, but for the most part, it doesn't massively increase your blood pressure. Masteron, those would probably be top three. Then we have, obviously with Masteron, we have Proviron. And then, yeah, those are the ones that like I can think of at the top of my head where I would be like not as worried about the heart.
Do you also
so I don't know, like from your experience, what you think.
Yeah, I kind of agree with you. Like, but do you also think that like total androgen load is important when it comes to cardiac remodeling? So, like, heart gets also
exactly, yeah.
So, like, if we are using highly androgenic steroids, there is more chance of us developing left ventricular hypertrophy than if we are keeping like our androgenic load low. You know, so maybe we are using low test and add in like something like, I don't know, Nandrolone or Anavar or Primo, which are less androgenic. Do you think that's also important?
So yeah, I have like had that discussion before, where the thing is with that whole stimulation of the androgen receptors within the heart, that was done in an in vitro study, and they have shown it in some animal models, but from clinical standpoints, when we do have high doses of androgens in our system, it actually hasn't really caused hypertrophy. And the times that we do have hypertrophy in individuals using steroids, it tends to be when we haven't controlled for confounding risk factors such as raised blood pressure, which is the biggest risk factor. So I definitely get where that thinking is from, but from my research, I don't think the stimulation of androgen receptors within the heart plays as much as a role as a lot of people might think it does. Obviously, I could be wrong about that, but just from overall, just looking through the studies, yes, it does stimulate the androgen receptors, but when we look at it in a clinical standpoint, we haven't really seen that. Like when they did a lot of studies back in the days where they used high doses in males, such as high dose testosterone and such, there was never a significant change to their ECG, which you could easily pick up. You can measure the change in left ventricular volume on an ECG, and we've never really seen that. So I don't know. I would say that, I don't know. So from my standpoint, it doesn't make as much of an impact, but I'm curious to see what you think.
No, actually, I asked you that because, like, I don't know much about, like, I was skeptical about this too. Like, I was like, okay, so if we use, like, less androgenic steroids, will this really, like, that much decrease our left ventricular hypertrophy or anything like that, you know? But, like, I also think that, like, the most important thing is, like, you controlling your blood pressure and your renin-angiotensin-aldosterone system overactivation more than, like, probably, like, if you're using, like, Masteron, right, it's highly androgenic. So if you're using, like, 100 testosterone and then you, like, use 1 gram of Masteron on top, it probably won't cause that much of a left ventricular hypertrophy than if you use, like, I don't know, 500 test and 500 deca, which will put extra water weight on you and will have make you have higher blood pressure. Activate your rest system more, you know. So yeah, I definitely agree with you on this. So I think that's pretty much it. Is there anything more that you want to add or anything?
Well, I mean, I don't know, I'll give my opinion, and then I don't know if you'd agree with me or not, but in terms of steroids that are worst for your heart, by far, Nandrolone is probably the worst I've come across. And it's not from the standpoint of hypertrophy. but just from the arrhythmias that nandrolone causes, and it's just understated. And I know many clients who have used nandrolone, and they say like they just get palpitations all the time, and that's because it causes these like ectopic beats that if they occur too often can sometimes lead to something like a supraventricular tachycardia if the ectopic beats are coming from the atrium. But these DECA is known to cause arrhythmias, and I've seen it before, and it really causes these odd-looking ECGs when it's dosed too high. So it's just something that I think is important. I don't know if you've come across it or if you think it's as much as a problem as I'm making it out to be, but
I never used nandrolone myself, but I've heard this a lot of the times. I also don't like really to use it with clients because like it's a it's a bit like complicated compound, like if someone is a beginner steroid user or something, I just think it's not needed because like, as soon as you add like nandrolone with testosterone, you're creating like a lot of possible side effects, like you're increasing aromatization of testosterone. Therefore, you might need to implement the aromatase inhibitor. Then you are also having the potential prolactin increase and potential need for implementing things like cabergoline or something like that in order to control prolactin. So that's why like I see uses for nandrolone. I definitely think it's a really powerful bulking agent. So I don't really shit on it like, okay, it's useless, like you should never use it. But with myself and with my clients, I find other things to be better. So for example, I'm a big fan of DHT. I'm a big fan of DHT. So I usually go testosterone and then I add DHTs on top. And I don't even use aromatase inhibitor. I just control my estrogen through testosterone to DHT ratio. So for example, my cycles would look something like 400 milligrams of testosterone plus 400 milligrams of masteron or primo, and then I would add like maybe a little bit of anavar on top or something like that. So I usually like find DHTs to be really good because they are like very easy to control. Like yes, they can affect lipid state, but they usually don't affect blood pressure that much because they don't cause water retention, and
they're a lot drier.
And they also don't cause any like aromatization or prolactin increase or anything like that. So they are like much easier to handle than if you're combining like test with 19 or derivatives or stuff like that, And I also like to point out, I would say that like D-bol is also very horrible for the cardiovascular system.
D-bol, yeah.
Do you have any experiences with it? Ever took it?
With D-bol?
Mm-hmm.
Well, in terms of dianabol, it's quite a common drug used here, and a lot of kids like using D-bol. But yeah, I've seen there was one circumstance where a 16-year-old had a blood pressure of 170 over like not 60, but like 90. And eventually it was found out he was using D-bol at like 20 milligrams, which doesn't sound like a lot, but it caused enough. He came in presenting with headaches. So it's like, I don't know, it's obviously a very potent compound, but for the average individual, maybe it's not really necessary.
Yeah, sure. Okay, so we're getting pretty long now, about an hour of podcast. I think we've covered enough. Thanks for you guys for watching. Like, if you made it till the end, thanks for you for being on my channel, and I hope we'll make
thank you for having me
podcast in the future. And see you in next video. And like always, don't forget to like, subscribe, and comment to support the channel's growth. And go check Nicholas' channel. He has very similar YouTube channel to mine, approximately same amount of subscribers. So definitely go check him out because he has plenty of useful information about PEDs, harm reduction, and all that. So have a great day and see you next video.